So now I will next call upon stage Dr. Sonali Rao for her talk on the impact of screen time on ocular surface in children. So I think this is a very important subject that we all need to discuss, not only for our patients but also for our own children. And Dr. Sonali Rao, this is the Hanumanta Reddy Award. She has received the award for her talk on this. And Dr. Sonali Rao is working at Lions Hospital, a renowned pediatric ophthalmologist in Lions Hospital, Bangalore.
Good afternoon. So after all that myopia talk, I'm going to talk about the impact of screen time on ocular surface in children. So we know that the daily media consumption has increased in today's pediatric age group, and the use of smartphones and tablets is the new normal. And after COVID, the increase used often leads to a variety of asthenopic symptoms. So we know that the pediatric population is more tolerant to these symptoms generally, but many of them go undiagnosed. So there is a strong need for a uniform protocol to screen for dry eye disease irrespective of symptoms. So what did we do? We wanted to evaluate the impact of electronic media use on the ocular surface health in children. So this was a cross-sectional observational study that was done in our OPD between September 2019 to October 2020 in the age group of 5 to 15 years who were using the appropriate spectacle correction. We excluded children with congenital abnormalities of the eye, severe allergy, trauma, or any other pre-existing ocular conditions. So the regular statistical analysis was used. So we included 78 children in our study, and each child, actually the parent, was given a standardized questionnaire to answer. A standard ophthalmic evaluation, slit lamp and fundus examination was done, and we did the dry eye evaluation using the OSDI scoring, Schirmer's test, tear breakup time, and fluorescence staining. So this was a questionnaire that was given to the parent. So we analyzed a total of 78 children, mean age of 11 years. We had 42% females and 57% were males. So coming to the percentage of device use, we can see that 45% of the children, they use smartphone and television, whereas 19% used all three devices, that is smartphone, television and computer, 19% only smartphone, 12% smartphone and computer, and 5% only television. So based on the screen time, we divided the population into study control group and study group. So control group were the children who use less than 1 hour of smartphone, and this was divided into control 1 and control 2. So children who use less than 3 hours of other media were control 1 and more than 3 hours of other media were control 2. Whereas in the study group, if children use less than 3 hours of other media, they were in study 1, more than 3 hours of other media study 2, and more than 4 hours of smartphone were in study 3. So here we have around 41 subjects in study 1, 6 subjects in study 2 and 3, and 4 in control 2 and 21 in control 1. So when we analyzed, we had the percentage of those with symptoms increased as the screen time increased. As you can see here, in the study group 2 and 3, almost 100% of them had symptoms. So the symptoms were headache, tearing, burning sensation, and headache was the most predominant symptom. So then we analyzed the OSDI scoring in all these kids, and OSDI scoring was greater than 12 in almost 57.7% of the population. So you can see here that the OSDI scoring is increasing as the screen time increases with a significant p-value of 0.001%. Then we come to the Schirmer's test. So once we analyze the Schirmer's test, we realize that as the electronic media use increased, the Schirmer's value also decreased with a p-value of 0.06 in the right eye, and it was significant in the left eye with 0.02. So though none of the study population had a Schirmer's value of less than 10 seconds, but it showed a decreasing trend as the duration of screen time increased. Next, coming to the tear breakup time. So even in the tear breakup time, we can see that as the electronic media use increased, the tear breakup time decreased. So there was a significant decrease in the T-but across all the groups as the duration of screen time increased, with a significant p-value being 0.001 in both eyes. Next, coming to the fluorescent staining. Fluorescent staining was noted in 7.7% of the population, though it was not clinically significant, but you can see that fluorescent staining was higher in those children who use more screen time. So comparing our study to the other studies in literature, so there are 3 studies. The first was done by Jung Choi. He compared adults. So he compared smartphone versus OSDI score, and he said that smartphone use aggravated the OSDI score. The second study by June Moon et al. They did a study on children. They compared 288 children. They evaluated the electronic media use versus TBUT and fluorescent staining, and they said that smartphone is an important dry eye risk factor in children. Another study by Katharina, she also compared 322 children between the age group of 3 and 10 years. They compared smartphone versus visual issues, and she concluded that asthenopic symptoms was higher in the video game group. The only study that contradicts our study was that was by Benjamin, but he had evaluated 344 adults. He compared the commonly used dry eyes like us, like Schirmer's test, T-BUT, OSDI, and fluorescent staining, but he did not find any demonstrable concordance between any of the signs or symptoms. So our study revealed that a significant portion of the study population had symptoms. The OSDI score showed significant increase in those with very high smartphone usage. The TBUT also showed a decreasing trend as the screen time increased. While not statistically significant, fluorescent staining was also higher in the group with high media use. So while the results did not indicate a severe disease, OSDI TBUT values, they did show a significant change as the duration of screen time increased. So in this generation of ever increasing dependency on electronic media devices, both the children and parents need to be aware of the ill effects. So study like these compare the direct effects of screen time on ocular surface health become more important. Our drawback of the study was that it was a small size and limited duration of only 1 year. So there is a need for more holistic diagnostic policy that can diagnose dry eye before the apparent symptomatic manifestation. Thank you.
Thank you, Dr. Sonali. Dr. Sonali received the best paper in pediatric ophthalmology for this study of hers. So I think if we have any audience questions, we can go on to that. Yes, please.
Mike. So, myopic astigmatism in children, we know anyway would tend to come down with time. And there is no evidence or no particular reason. So, the effect of atropine is to be on the axial length. And almost always the astigmatism is anterior segment in origin, unless there's a tilted disc or something. But most commonly it is corneal. So, if you have high astigmatism, identify and look for keratoconus or form fructic keratoconus. Follow up the child for that. But up to 3 diopters of astigmatism in a young child up to 3, 4 years, 6 years is not very uncommon, provided it's not causing amblyopia. I would just say correct it, refractive error correction, and follow up.
And also, if all these studies have proven the role of atropine only in simple childhood myopia, not for secondary myopias, although it's being used off-label in a lot of other myopia related to ROP, high myopia. Even in high myopia, the role is not proven. But studies are still underway, and maybe in future we'll have the results and some evidence supporting it. But as of now, the evidence just supports its role in simple, mild to moderate childhood myopia.
Yes, ma'am. So, peripheral refraction is the refractive error in the mid periphery of the globe. So, the basic hypothesis is that which you gave single vision glasses correct for the foveal refractive error, but the retina at the back or the sclera is not an absolute round ball. It's oblate, so there is a change, and the peripheral part shows a hyperopic refractive error, and that is the cause for myopic progression. So essentially, theoretically, you can do it by asking the patient to look off axis, get a measured distance, give an angle change and give a fixing target so that it's about 25 or 30 degrees off center. So the patient is looking off center and you're doing your refraction from straight head on, and you're refracting or neutralizing that part. So that is peripheral refraction. Lot of handy devices have come in, including from LVPI and or the Jethani, which are kind of like, help you to do that give you a correct fixating target so that you can do that retinoscopy or refraction that you're doing. Of course, commercially available open ARs are there. So in a normal AR, you're looking straight and you're supposed to look at the light. These are open ARs which have lights which are at different degrees from the primary axis. So the patient looks there and the machine does the AR at that 25 degree or whatever. So that is peripheral refraction.
So basically, it helps you understand that the peripheral hyperopic defocus, it's happening somewhere around 20, 30 degrees of the retina. So that has been most studied, 20, 30, 40 degrees, and studies have shown that around 30 degrees somewhere the hyperopic defocus is happening. That's probably a stimulus for your myopic growth. So if you find this peripheral defocus, accordingly you can probably go for optical interventions that provide a peripheral add. If the child -3, the child who is already having myopia, and we'll have to look at the risk factors. If as sir discussed, if the risk factors are high, we need to definitely start the therapy in the child. Sorry.
Why it happened?
Oh,
So,
why?
so, so two children are brilliant, one child is not so. Two children are fair. So there's a huge genetic variation in the refract. So emetropia is not zero refractive error. Emetropization means that the eye should remain at rest for the longest duration of time without spending energy. The moment you look near, the brain is actually expending energy. So that is why we know generation by generation we are becoming myopic, because myopes see near without any trouble. So for the brain, the feedback is that a myopic eye is no work at all. That is why. So some children have a more tendency, depending upon their epigenetic makeup, depending upon their environmental or no, so the genes may be same. So even twins are different.
I think I covered it in my talk. The penetrance of myopia gene is only 5%. So even if you have the gene, you may not manifest myopia in 95% cases. And if you have one parent as myopic, you have only 10% risk of myopia. And if you have both parents myopic, you have a 25 to 40% risk of myopia. So I think that answers the question. I mean, all three may have the gene. In one child, it may manifest. In the other two, it may not manifest. It doesn't mean that they don't have the gene.
Or the risk.
Pardon? Depending on. So if you go through the American Academy of Pediatrics preferred practice patterns on amblyopia.
You mean myopic glasses or myopic glasses?
Myopic glasses. So it is a need-based thing. So if you have a child who is 2 years old and he's -1, you won't prescribe it. If it's a 5-year-old child, he's got -1, you'll prescribe it.
So also we need to document the progression first. Unless you document the progression, it's always a good idea to wait for maybe 3 months or 6 months and look at the change that is happening, as sir was discussing. Get the baseline curve, that how the myopia, how much it's progressing. So once you get the baseline rate of progression, after that you can plan whether some intervention is needed or not. Ideally, I would think that if there is no previous records of the child showing the prescription or anything, and it's a first time contact, wait for the child. First time you are prescribing, then wait for another few months. If there is a progression, look at that rate, how much it's progressed in 6 months or 3 months. And then
what will be the progression you would expect in 3 months?
In 3 months, we will not expect much. But if it is a high myopia rapid progressor, maybe in 3 months also we can see some change. But 6 months, definitely you can see some change. 6 months would be an ideal thing, as you say. 3 months is less, but in rapid progressors, you might even see.
Last, I think.
I've been monitoring Linstar, and in those patients who in 6 months about 0.1 mm increase in axial length, they generally don't have change in refractive error. Now, is that probably the non-axial length causes you were talking about change in that case? Have you observed that?
So that is one of the possibilities. Yes, there is always that little disconnect. The other thing is there is always that least count that is there. So the measurable distance by different machines and different refractive error measurements, how much we are taking as our least count for difference. So I would say yes, there is a disconnect, and as I said, our thought was that probably it's anterior segment in relation, but the disconnect is only very modest. So if you are again on sequential follow-up seeing and observing axial end change, it obviously is a cause for concern. Why it is not reflecting the refractive error change is something that, like, every child you need to check whether there is an anterior segment change in power or not, lens power or not.
Monitoring of pre-myopia, what
Yeah.
is your cutoff for calling it progression on the basis of axial you are monitoring over 6 months or 1 year?
So essentially equivalent to the way we would call progression in myopes. So 0.5 diopter progression is progression, 0.5 change, either reduction in hyperopia or shift towards myopia would be for refractive error. For axial length, 0.3 is usually what we are taking as a significant change.
Over 6 months or over 1 year?
So ideally it should be over 1 year. This is an 1 year calculation that I am saying. So all our studies are measured for 1 year. We are extrapolating it at 6 months because we may be concerned about a rapid progression and may apply it at 6 months. But all progression decisions are essentially based on change over a year.
I'm just answering your first question. The 0.1 mm change is can bring about 0.2 to 0.25 diopters change in the refractive error. So it probably might be missed.
Yeah, exactly. So least count maybe that.
This is just an observation.
Yes.
You mentioned
So-
about those factors.
Yeah, it could be, like I said, that could be possible. It could just be part of variability. Unless it's consistently showing, it may not be.